Good evening, everyone. Can you hear me? My name is Mohammed Missel. I'm Assistant Registrar in General Surgery at Mubarak Kabir Hospital, and I am a member of Surgery Kuwait. I'm honored to be your host for the evening. Tonight, we are pleased to have Dr. Alexander Lee as our speaker. He will give us a speak about the motility disorders of the esophagus and surgical approach. Dr. Lee is a thoracic surgery fellow, thoracic foregut and MIS transplant, a program director of Thoracic Surgery and Surgical Foundation. He's a vice president of PS Chest Surgery Surgeon Association. A quick reminder, if you have any question, don't hesitate to write it in the questionnaire panel. Dr. Lee, the mic is yours.
Thanks a lot. It's a real pleasure to be here again. And we'll chat about motility disorders and testing, and then spend a fair bit of time on Achalasia, because that's the entity that we do the most of our operating for. And we'll go over that in turn. Just let me get my big slide up. Okay, so motility disorders and testing. And I do have a declaration. One of my friends and colleagues, a gastroenterologist, she gave me some of her slides to add in, so this should be good. And she truly is our provincial lead in motility disorders in British Columbia. And as discussed, we'll be chatting about these things. So testing. Whenever we think about testing of the esophagus, I think most people think that the best test of the esophagus is endoscopy. Well, endoscopy is great if you're looking for a specific mechanical problem, but not so good for physiology. And oftentimes when you see a report from endoscopy, there's no comment on things that I want to get a sense of, meaning, was there any peristalsis? Was the lower esophageal sphincter loose? Was there pooling of saliva in the esophagus? Was there bile in the stomach? This kind of thing. So in testing for physiology, there's the good versus the bad. And there's lots of questionnaires out there, but people don't really get a sense of what we're asking when we ask for dysphagia. When we ask dysphagia, do you have trouble swallowing? Well, that's an awareness of putting food in your mouth to get into the esophagus. They don't seem to think that that means clearance of the esophagus. And sometimes people who have dysphagia believe that they have reflux when stuff is just sitting in the esophagus and comes up. Reflux is when stuff in the stomach comes up rather than pooling. So there's often a misdiagnosis. And again, scope may not give you the information that you want. So really the best tests for esophageal function is a barium swallow and a so-called high-resolution manometry. I put this in EndoFlip. This is a thing that the GI people do. It's a through-the-scope balloon with sensors on it. But for our purposes, I think it's cool enough to know what it is. But, we would never be interpreting or doing that sort of thing. So barium swallow is good because when they swallow the contrast, you could see, is the contrast going into the esophagus or is there an immediate aspiration? Stuff gets into the esophagus. Is there peristalsis? Is there poor clearance? Is there pooling? And then if there's pooling in the esophagus, does that come back up and spill into the airway? Does the contrast get into the stomach at all? And is there reflux? So it gives you a nice visual sense of what's happening. But in terms of the very specific diagnoses, high-resolution manometry is essential when someone is very symptomatic. So this is an example of high-resolution manometry. And in the olden days, you'd see a pressure tracing. And this is a probe that's sitting in the esophagus and across the GE junction. And you get a sense of a pressure wave. Now, at the top is the upper esophageal sphincter, and the bottom is the lower esophageal sphincter. Blue is no pressure, red is pressure, and green is you're approaching to get pressure. So anywhere you see blue, there's no pressure. So at the top of the colored image, you'll see an area where there's blue. That's when the swallow is initiated. So there's no pressure in the upper esophageal sphincter. And as soon as something gets into the esophagus, it closes back up. to avoid aspiration. If you notice at the bottom, there's a lot of blue at the bottom, meaning already the lower esophageal sphincter's pressure is dipped down. And you'll see that in the squiggly line to the left. And what is normal is this propagation of pressure wave where there is an amplitude and a wavelength. So this is what a normal swallow should look like. And again, I'm not a super expert on this. I don't do these tests myself, but I should be able to know as a surgeon, hey, what does the report mean? And to be able to have a useful conversation with the gastroenterologist and at least to interpret what these images look like on the basics. This is indications and contraindications. The most important thing is the bottom. What are the contraindications? They have to be conscious and they can't have a recent skull fracture. You don't want the probe going in the person's brain. Standard protocol, stop all medications that could affect the test. And most importantly, the opiates, because opiates can cause dysfunction. And it's good to know what is happening when they're on or off. And oftentimes people say, well, my swallowing improved around that time that we did that test. And that seems to indicate that the opiates may be a cause. So this is the Chicago classification. And for most people's understanding, a catheter is placed, and you would think that should get into the stomach, and sometimes it doesn't. And in cases where you really need to know, you can do it at the same time of endoscopy just to drag it in. But most endoscopy units are not the same as the motility lab room. And 10 swallows, supine, followed by 5 upright swallows. And then the bottom stuff, this is when the gastroenterologist is looking for some very specific things. You know, multiple rapid swallowing, rapid drink challenge, postprandial meal, all this kind of stuff. This is the very advanced stuff that they would do to get a diagnosis. As a surgeon, I really am not equipped to working these patients up to this degree and to trialing different medications that I don't know how to spell or complications of. So really, when someone has a very complicated problem, it's my preference to have them seen by a gastroenterologist and to be sorted. And then we have a group discussion between her or I, where we say, look, this is what I think we need to do because there are different treatment options. So again, here's the standard manometry of a normal swallow. And this is interesting. If I were to drop something 25 centimeters, the length of my esophagus, it would land within under a second. This seems to show that the swallowing time of a bolus of food takes anywhere from 5 to 10 seconds. So the swallowing is slower than gravity. So with swallowing, there's blue at the top, where there's no pressure at the upper esophageal sphincter. And then immediately when the food goes through, it closes, that red tightness at the top. Down at the bottom, there's this blue area, again, where there's a loss of pressure at the lower esophageal sphincter. And then this propagation over time. And what we're looking at is the redness, how much pressure is there, and the width. And that becomes important as we look at some other pictures down the road. Now, this is what the gastroenterologist would do. At every stage, they would look at different things, and this is how they can get a diagnosis. So this is for your reference, and I'll send this to you as well. And I don't really want to go through this all. Here's some pictures. Now, the normal at the top, that should be recognizable to someone writing a thoracic and foregut exam. And then diffuse esophageal spasm. You notice how there's not this propagation. It's all lined up, meaning it's contracting at the same time. Type 1 achalasia down in the bottom right, it's blue throughout, meaning there's no peristalsis. Type 2 achalasia, you see that green area? That means there's no peristalsis, but there's an increase in pressure in the esophagus. So that's what's called pressurization. And then type 3, where you have that wide band of red to some degree, that is spasm throughout the duration of a swallow that's not propagating and not purposeful. So again, these are things that a fellow, Dr. Iesa, should be able to know when he writes our exam next year. And again, there's these provocative testing maneuvers that they do that we can just skip by. So barium swallow, we talked about how useful that is. A timed barium swallow is where you do the barium swallow and you just don't quickly usher them out of the way. You sit there and videotape them for a while. So this is a little bit different than a speech language pathology assessment or a standard barium swallow. This is to say, let's see what happens and time it. How long does the esophagus take to clear, if at all? So this is an example of someone with achalasia. And what we see is a dilated esophagus and a so-called bird's beak. So that is definitely a dilated esophagus, but there still is a sense of gravity to it. So when I see this person probably is going to benefit from some type of intervention locally at the GE junction. So let's talk about the medical aspects of achalasia. What exactly is it? Well, there's aperistalsis. This is what it is from a pathophysiology point of view, and failure of the LES to relax. Okay, so it's both no peristalsis and failure of the LES to relax. And this type 1, 2, and 3, this all came from the high resolution manometry. But for my purposes, I want to get a sense of, is the lower esophageal sphincter tight? And if so, can they tolerate an operation? And if not, should we be thinking about Botox, balloon dilatation, or POEM? And POEM is a per-oral approach. So nothing can cure the esophagus's function, but the goal is to reduce the hypertonicity at the lower end so it could empty basically by gravity or whatever function there might be. So again, there's medications, endoscopy, and surgical. And if we think about medications, we're trying to loosen muscle. And what medications might be used for that, there's nothing specific to the esophagus. Similarly, there's no medication specific to the stomach. We think Maxaran and domperidone are, but they're not. And of course, these medications that are off-label that we're using have their, what we would consider side effects, but their normal effect for their original use. And then I think about, well, are they a candidate for surgery? Have they had 5 operations to the GE junction already? Do they have some other comorbid problems? Have they had a prior perforation there? Have they had a prior myotomy via POEM or surgery? And yet always have to factor in patient preference and local expertise. Medications are not specific to the esophagus, and something to loosen muscle, well, calcium channel blockers, nitrates, sildenafil, all these things are not specific, and you are limited with the primary effect, hypotension, headache, edema, and so forth. It's worthwhile trying in someone who is not a candidate for intervention, but there's a very modest improvement. Botox, as you can imagine, works by inhibiting acetylcholine release. So if you have a very focal area where there's dysfunction, you could think about doing it right at the GE junction. So if you think that the problem is specifically at the GE junction, then you could do a 4-quadrant injection. That makes sense to me. When someone has diffuse spasm, or I think we're all aware, jackhammer, where the whole length has got a problem, it's really difficult to do a 4-quadrant Botox to the entire length. So really Botox, in theory, is great for a focal lesion. Also for the pylorus when someone has gastroparesis. So a very focal area that is treatable and easy to do. One would imagine, just like Botox for plastic surgery, it doesn't last very long. So several studies have shown in the first month, results are reasonably comparable to balloon dilatation or myotomy, but it wears off. So what might we think about using Botox in? Well, someone with achalasia, someone who might be high risk for surgery or frail, or came into hospital with known achalasia, then there is a precipitous decline in swallowing mechanism, and then they can't even swallow their own saliva. So sometimes we bring these patients in and we have an option. Do we do an upfront operation this weekend? Or do we just say, let's do Botox, see if we can get them out of the hospital? Downside of the Botox is that people say, well, if you're injecting, you're puncturing the mucosa, there could be scarring leading to stickiness of the mucosa to the muscle layer, making your eventual operation somewhat problematic, in that you might do a myotomy where there's a hole in the mucosa after you've done your myotomy and so forth. So I'm not sure if that's really that true. But again, I think it's important to work collaboratively where you speak to the gastroenterologist and say, like, what do we want to do here? And come up with a decision together. And yes, there have been times that in a patient who comes in, can't swallow their own saliva, sometimes we do the Botox and see what happens. Sometimes we just do a Heller myotomy. Pneumatic dilatation. The through the scope balloon that we commonly use, the one that I use, the Boston Scientific balloon, is 20 millimeters. This is different. These are balloons that are 30 to 40 millimeters, and they are under fluoro or endoscopic guidance. And this slide was given to me by Sarvi, the gastroenterologist, and she said, hey, look, anybody you're going to do something like this on, you have to have a plan if there is a perforation. And in the textbooks, anywhere from 0 to 10%, depending on who's quoting. I think most experts quote around a 2%. One might expect that there is a risk of reflux afterwards. But again, you're trying to balance the benefit of clearance of the esophagus versus the chance of reflux, where you might need to be on a medication. And yes, there have been times when someone has achalasia and a normal lining to the esophagus, you do a procedure for achalasia, you give them reflux, and then they develop a stricture because of reflux and they have swallowing trouble again. So this is this balance that we're trying to play to not only prevent reflux symptoms, but to also prevent reflux complication. Like most things, the effect wears off. So myotomy. Myotomy is first done by Heller, and this is an abdominal approach where the muscle fibers are divided. And most of the time it's laparoscopic now, and symptom improvement you can pretty much predict. Long-term follow-up efficacy decreases, but I think I can spot who that might be. When someone has been diagnosed early and the esophagus is nice and straight and there is no hiatus hernia, and if I've done a very minimal dissection around the esophagus to do the myotomy and then add on a partial fundoplication, I think the results in that person is going to be very good. I put this here that the textbooks say, well, for type 3 achalasia, where there is a spasm component, they don't have as good success as the other types. That seems to make sense. We've loosened the lower esophageal sphincter, but we haven't really fixed the spasm component. So reflux, you've loosened the lower esophageal sphincter. There is a chance of getting reflux. So when you look at studies comparing Heller alone versus Heller and a partial wrap, these studies show that a partial wrap has less reflux. I think that's true. If you compare Heller and fundoplication, a wrap, Heller and a partial wrap versus POEM, well, POEM is like a Heller. There is no wrap. So one would expect that reflux would be less with a Heller and a fundo. And in a randomized trial, small numbers, one group found that if you did a posterior toupee, there's less reflux. So I think this to me says, if ever I'm going to do a procedure for achalasia, I don't want to cause reflux, meaning I don't want to take down all the anti-reflux mechanisms, such as giving the patient a hiatus hernia, completely dissecting out the phrenoesophageal ligament, and I do want to add a wrap of some kind. And Dr. Achalasia will tell you, hey, sometimes I do the anterior door, the front door, or the posterior toupee. The posterior toupee takes a little longer, I think, slightly. But in my mind, either are good. Most people do the anterior door because it's easier. POEM, peroral endoscopic myotomy. This is where a special scope with an insufflator and another channel is advanced into the esophagus, and you make an incision in the mucosa and then dissect out a tunnel, a submucosal tunnel, and then you divide the muscle fibers in a similar way you would the lower part of the esophagus and across the GE junction to some degree. And you obviously leave the adventitia intact, and then you close the mucosa with clips. This is easier said than done. And looking at a big center in China, the 5-year good result, meaning no further therapy needed, and an Eckhart score of less than 3, 90% good result. I think we can appreciate the complications that can occur. Bleeding, that's number 1. Hydrothorax, pneumothorax, mediastinitis, this sort of thing. Now, again, they do make a big deal about type 3, and I would say that a good thought process has to be there in saying, look, if the lower esophageal sphincter is tight, and that predominantly is what's causing the grief, then doing a myotomy or a POEM makes sense. If there isn't a lot of tightness at the lower end and there's more of a spasm component, then I think we're thinking that the results may not be as good. But in terms of overall results, they're almost as good. And we chatted about adverse events. Now, in terms of reflux, when we look for POEM versus pneumatic dilatation, they say here, this is interesting. They say 40% of people who have had POEM had reflux versus only 7% for pneumatic dilatation at 2 years. This seems to, you have to appreciate what this is really saying though. If the result of the myotomy is so good at 2 years, you are going to get reflux. But as we know, with pneumatic dilatation, the effective therapy wears off. So yes, you don't have reflux, but you, at the end of 2 years, you still have a lot of dysphagia. And what's hidden in some of these studies is how many times the pneumatic dilatation has been done. So I'll show you some studies where, hey, look, we do 1 Heller myotomy or 1 POEM is done versus over the span of 2 or 3 years, 9 endoscopies and dilations, where there is a perforation risk. And as well, the patient comes in for a procedure, an endoscopy, and can't work the next day. So these are all the things that you have to factor in. So this is a nice summary of, hey, look, what are the pros and cons of pneumatic dilatation, POEM, LHM, laparoscopic Heller myotomy. And this is kind of nice because it just says it all here. And again, I'll send this presentation to you, and then each resident can have it. I have this nice volumes of all my presentations that I give all my residents so they can have and read before the teaching session, so they know exactly what questions I'm going to ask, because I always ask the same ones over and over again. Okay, outlet obstruction. Well, what does this mean? It means that there's something specific at the gastroesophageal junction and not really sure what this is about. So here's a nice summary: achalasia versus outlet obstruction, EJGOO. So there's some problem with relaxation at the lower esophageal sphincter. But in the outlet obstruction, there is some peristalsis. So you don't have a diagnosis of achalasia. Achalasia is aperistalsis and failure of the LES to relax. For outlet obstruction, there could be some other problem. It could be reflux, it could be a stricture, a failed hiatus hernia, a slipped wrap, whatever. It could be something else, opioid induced. Now, sometimes with other therapy, it gets better. So if we do believe it's opioid induced, stopping that medication could help. Hey, look, if there is a stricture component because of reflux, treat the reflux, do a balloon dilation and see what happens. Okay, so with achalasia, the lower esophageal sphincter is dysfunctional. There's no stricture there. There may be an element of scarring or a stricture for outlet obstruction. So that's the difference. So for a thoracic fellow, there might be a 10-mark question. What is the difference between achalasia and outlet obstruction from a myotomy point, from a manometry point of view and or cause, etc. They like that kind of question on the Royal College exams. And again, causes, we chatted about it. It could be a mechanical problem, opioid induced. And I have to admit, I didn't really appreciate that as much. And quite honestly, a lot of people are on opioids. So it's a good question to ask, because we tend to be fixated on either mechanical problem or some type of dysmotility. How do we treat this? We want to rule out a mechanical obstruction. Same thing for achalasia. You want to rule out pseudoachalasia, something that looks like it could be something else. And we've always said this. We want to rule out a cancer. Dr. Iesa and I took a patient to the operating room that we thought had achalasia based on endoscopy and motility. And then we actually get into the operating room, we see tumor on the outside of the esophagus. And you know what, if there is some sense of dysfunction, you really believe that there is failure of the LES to relax, there's a thickened muscle band, and you could think about balloon dilatation, POEM, and even a Heller myotomy. But very limited data. So again, this is where you want to be working with your gastroenterologist, an expert, to tell you, hey, what does he or she think is really going on here, and what are we going to do? If you do an endoscopy and you see a stricture with esophagitis everywhere, I'm not sure that that's going to respond to a myotomy. So another characteristic, and this is from the Chicago classification, spastic disorders. So esophageal spasm and hypercontractile or jackhammer. So a classic question is, which one's painful? Spasm is where 20% of swallows, it contracts at the same time. So there's no propagation. That's not painful. Whereas a jackhammer is a very high amplitude, a high pressure, and a prolonged wavelength. So that leads to pain. So that's a classic question that gets asked. So here's diffuse esophageal spasm. Again, what we're seeing at the top is the initiation of the swallow, that blue part, and then a tightening up again of the upper esophageal sphincter. And then rather than a progression over 5 to 10 seconds, you see a vertical tightness. So that is obviously spasm. This is different. If you notice, high colors of red, so high pressures, pressures that are higher than your systemic blood pressure, you do have some sense of propagation, but look how wide the wavelength is. So there's a prolonged amount of time where there is contraction. So not only super tight contraction, but rather than a 1 second or 2 second contraction at a specific site, it's 10 seconds. So that's painful. So again, for your purposes, treatments, there are smooth muscle relaxants, neuromodulators, Botox, and surgery. And this is not great. Doing surgery or POEM in these settings are not great. And the results are very poor. So again, here's a rather basic treatment algorithm. This makes sense. Stop the opioids, give a PPI, try the peppermint oil or some of these medications, try Botox, but it's very difficult to treat Botox along the entire length of the esophagus. And once you get to this bottom part, you really do want to have a good consensus amongst the group to say, where are we going here? I had a patient who had a jackhammer esophagus, and I said, well, you know what? All has failed. Let's try a long thoracic myotomy. So we did a myotomy for almost the entire length of the thoracic esophagus. And the patient said, oh, I feel so much better. And then a year later it comes back, and now the esophagus is super dilated because it's almost as if he blew out the mucosa. So now he has dysphagia for another reason, quite a baggy, giant esophagus. So we ended up having to do an esophagectomy for this person. Sometimes this gets better on its own. And again, be very cautious in thinking about doing a procedure for this patient. And I suppose doing a POEM procedure doesn't involve laparoscopic or VAT surgery, and it's a reasonable thought to do that first. Ineffective motility. I'm sure everyone's heard the term presbyesophagus. This was a radiologic term from 30, 40, 50 years ago, where at Barium Swallow, there's this kind of corkscrew appearance where the Barium Swallow doesn't pass. And it's just thought, well, esophagus is lazy or poor peristalsis. We call this ineffective motility, where in essence, there is some sense of a propagation, a pressure wave, but it's far too weak. And you can see it in eosinophilic esophagus, connective tissue disorders, Parkinson's. Sometimes it could be related to reflux. And so, people say, what's the most common reason why when someone has reflux, they also have dysmotility? Well, it's probably from the reflux. And if you treat the reflux, maybe that might get better. So this really is not a surgical problem. So medications such as mosaprine, but buspirone is the one that most people start off with. And again, I don't really see these people. Okay, I will. Question 1. I'm not sure how, Dr. Mohammed, you wanted to do this.
Hi, Dr.
1 second, we'll put the poll up.
Very good. I was going to vote, actually.
Doctor, you can read a minute to answer the question. Dr. Lee, you can hear me?
Yes, sir.
Yeah. If you don't mind, you can read the question for the audience, and we'll give them a minute to answer the question.
Sure. Question 1. What is the best test to diagnose a motility disorder? Barium Swallow, endoscopy, high-resolution manometry, or timed Barium Swallow? What is the best test to get a diagnosis?
We'll give them 15 seconds and we'll share the answers. Ending now.
Perfect. 69%. I'd agree with that. High resolution manometry.
We'll share the second question in 1 second.
All right. Classic Canadian Royal College question. What is false regarding something? What is false regarding achalasia type 2? Aperistalsis, spasm seen at high resolution manometry, the LES fails to relax, and lastly, there is pressurization of the esophagus. So which one of these four is wrong?
30 seconds left, and we'll share the question, the answer. Ending the ball now, and the results are
perfect. Spasm is seen with type 3.
excellent. Want us to move on the third question, Doctor?
Third question. What has the lowest chance of reflux after treatment for achalasia? What has the lowest chance of reflux after treatment for achalasia type 2? Poem, Heller alone, Heller plus anterior partial door, and lastly, Heller plus partial toupee.
Okay, 20 seconds. Don't hesitate to put your answer in. Ending now, we will show the result now.
All right, this is across the board here. In a very small study, it was found that a posterior toupee had the lowest chance of reflux. So I guess the point is, Poem and a Heller myotomy do the myotomy, whereas if you add in the door or the toupee, you're going to get less reflux. So that's why in my hands, if someone has a hiatus hernia, then I would not do a Poem because they're going to get bad reflux for sure. All right, those are great questions. Good answers too. I'm going to switch over now to the second talk. And this is specific about achalasia. And I'll try to skip over the stuff that we've already chatted. So really we're talking about how do we treat it? And then also so-called end-stage megaesophagus. So I do see patients that have so-called end-stage, and if they've had failed treatment from other interventions, be it Poem or prior surgery. So we know that it's a progressive degeneration of ganglion cells. It is not a harbinger of any other neurologic disorder. So this seems like it's a very weird, specific thing related to the esophagus and the myenteric plexus. And Chagas in some places, protozoal infection that can appear like achalasia. We had a fellow from Brazil and he said, oh yeah, this is very common. And the things at the bottom, these are the things that a thoracic fellow would need to rule out, and nothing worse than a 10-mark question. What are secondary causes of achalasia? And I was like, oh boy, I know Chagas, and there's all this other stuff that someone expects you to memorize. Okay, usually there's an insidious onset, progression of dysphagia to solids, then liquids, And again, this is regurgitation of saliva and undigested food. So people always say, oh, I've got bad reflux. Well, no, it's stuff that's sitting in the esophagus. Okay, so it hasn't gotten into the stomach. So reflux is acid from the stomach. Regurgitation, well, that could be food from the stomach or from the esophagus. So this is where it's hard to get a sense of what's happening. That's why there's commonly a delay in diagnosis. And they can aspirate. And sometimes it takes a long time for someone to get it right. Chest x-ray is mostly normal, but I'll show you an x-ray that isn't. So I think we can all appreciate that this is abnormal. So we see the trachea, and we see an air fluid level at the top. So that's air. And that opacity on the right side of the chest is a huge dilated esophagus, actually bigger than the stomach, believe it or not. So this is an end-stage esophagus. Early, there could be pooling of contrast on barium swallow. It could be dilated and tortuous. It's kind of like those cartoons where someone stands on a hose and it balloons out and gets tortuous. So-called sigmoid esophagus. That's where you have a picture where it's just so big and there's a flop under gravity. Physiology, you might see aspiration, you might see some spasm, you might see some tertiary waves, but you don't see reflux. You see poor clearance, but no reflux. So first picture, the classic picture. Second picture, this is where it's becoming tortuous and sigmoid-like. Endoscopy, when someone has early symptoms, it can often be reported as normal. And then you have a misdiagnosis for another long amount of time. But you do want to comment on all these things, not just the anatomy, but the physiology. And I comment on, oh, there's saliva in here. There shouldn't be saliva in there. And I want to comment, well, the lower esophageal sphincter looks snug, and with insufflation, it didn't open up at all. And yes, I did have to push the scope through. Oftentimes an endoscopist will say, well, it looked normal, and you're shoving the scope down. That's different than actual swallowing. Rule out cancer. Get a sense of what are the dysphagia mechanisms? Is there a flop? Is there a hiatus hernia? These are all things that you need to know when you're planning out your operation. Manometry, we talked about. We talked about the Chicago classification. And end stage. This is where you have this mega esophagus. And these are people who you actually think may need an esophagectomy. So here's a picture of, well, maybe not. I do have a picture somewhere. So we know what the goals of therapy are. Decrease the resting pressure in the LAS to allow things to empty with gravity. And you do want to prevent reflux. So in my mind, as I said already, when someone has a hiatus hernia, I'm for sure thinking that they need a Heller and a partial fundoplication and not a poem. So a low-risk patient, yes, you could try graded pneumatic dilatation, but in my mind, why would you do that when you have to repeat that? There's a risk of perforation, and I would rather just, if it were me or a family member, have them have a surgery or a poem. Because I do think that it's a one-stop deal with a good result. Great results, actually. Rather than coming back and forth for dilations, which carry a risk. And a dilation and a perforation is a serious thing because now you've got an abnormal esophagus, you've perforated it, and you're thinking, well, how am I going to fix the perforation? But then there's an underlying problem at the same area. So a pressurized area that you're trying to allow it to heal and repair. So think about that for a while. So this is what the balloon looks like. This is not a through the scope balloon. This is one that goes beside the scope. And that's what that is. So esophagus with the balloon in place. So again, there's some functional tightness here. If you perforate that, well, You have to think about fixing that, but how likely is that going to heal when there's an underlying problem there? And then second of all, if there's damage to the mucosa and or muscle layers, you could have scarring and adhesions, which may make it more challenging when someone actually does a POEM or a myotomy, in addition to a perforation risk. Case 1, 50-year-old woman, pneumatic dilatation, and she had an obvious perforation to the left of the esophagus. This actually happened last month. And there was an effusion and soilage to the left chest. And the CT of the abdomen and the right chest were normal. So there's a perforation here. So what we ended up doing is a standard 2-layer closure. We went into the left chest. We did a standard 2-layer closure where we found a mucosal defect, closed that with interrupted 2O vicryl, and then closed the muscle layer on top of it with 2O silk and put some pleura on top of it and an intercostal muscle bundle. But then in addition to that, we did a myotomy on the opposite side to not only deal with the perforation, but deal with the achalasia. So first described a long time ago, over 100 years ago, you do want to divide the muscle fibers to some length of the esophagus and crossing the GE junction across the stomach. And when you do it, you do get a sense that, oh, that's just opened up quite nicely. So what's at the front? The left vagus nerve. And you can use the cautery, you can use the ligature, you can use the harmonic, whatever you want to do. A bougie in place makes sense. Anywhere from a 46 to a 50. If it's too tight, then it's hard to get your hook underneath. And again, you do get a sense of what are the thickened muscle fibers. They do tend to thicken. And then once you start going north, you get the sense, oh, it's no longer thickened. And what I described to you about not destroying all the anti-reflux features, just like last time we talked about what prevents reflux. Well, a functional lower esophageal sphincter, an intra-abdominal component of the lower esophagus. So if we completely dissect out the hiatus and give them a hiatus hernia, we've destroyed that. All these attachments, the phrenoesophageal ligament and so forth, all these things matter. And if we completely dissect all that out, then you are giving them reflux in addition to loosening the lower esophageal sphincter. So again, you want a minimal dissection, do your muscle fiber bundle division, and then do either an anterior door or a posterior toupee. And that's exactly what I said. Don't stretch out the hiatus, avoid the vagus nerves. And, you know, I do like to anchor the fundoplication to both sides of the myotomy. I think in this last, there's a picture coming up, but if you put the flap on and you only anchor it to the far side, if there's tension, it'll rotate it. Whereas if you anchored them to both sides of the myotomy, there's less angulation and less pulling it back together. You know, keep going until it's thin, heading north, 6 centimeters up, 3 centimeters down. Some people actually inject some saline to raise it up. That's not a bad thing. Some people put a scope in at the beginning to use that like a bougie. I find a scope before laparoscopic surgery is a pain because it inflates your stomach and all the bowels. You only have to do that once to say, I'm not doing that again. But if you do a scope and you're trigger happy, inflating all this air into the bowels, then you're just fighting through all these dilated loops. It's a pain. Some people do a scope at the end, not unreasonable to do. This is where I'm getting at. Hey, look, door versus toupee, myotomy versus myotomy, myotomy alone versus wrap and so forth, the numbers really do show that adding on a anterior door or a posterior toupee reduces the risk of reflux. And yes, there was a small study by the same group suggesting that toupee may offer less of a risk of acid reflux. If you have a perforation, so you're doing a myotomy, oops, I got into the mucosa, I end up, that forces my hand to do an anterior repair, obviously. So I fix the hole in the mucosa and then sew the fundus anteriorly on top of it, plus lots of omentum. Okay, so sometimes if I was planning to do a toupee and got into that problem, switch it over to a door. Now, do people not do a anti-reflux procedure? Do people not do a fundoplication? Sometimes. If you have a normal intra-abdominal length of esophagus, a nice snug hiatus, and a nice angle of His, that angle between the esophagus and the fundus, and you've done a limited dissection, you may not need to do it. This is what people say when they don't. And it's easy enough for them to say, well, if they get into trouble, we can always do a Nissen later. Well, I tell you, going back in as a redo, very difficult, because if you've done a myotomy, you've got exposed mucosa, and anybody who does a lot of foregut surgery knows that it's like, oh my God, it's like glue, that the liver just glues onto that area. So, having a perforation at the time of redo hiatus surgery is not uncommon. So always be prepared for that. So here's my point about the anterior door. I do like to anchor some of it on both sides of the myotomy site without there being any tension or rotation. So if you think about it, the esophagus comes straight down to the stomach. If you have, say, not released the short gastrix and it's too tight and there's a corkscrew effect because of your wrap, that can actually lead to dysfunction. So risk of perforation, vagal nerve injury, and now we're giving them gastroparesis, which is not great if you did that. But good results, good durable results. So we chatted about this. Person had a prior Helleran door. Things went well, but then had dysphagia. Barium Swallow showed a holdup. And when I did endoscopy, I saw that kind of looked rotated. It seemed pinched. So we ended up doing an operation where I did a scope beforehand and laparoscopically, we just released the door, and lo and behold, it kind of just opened up quite nicely. So in this scenario, I thought that the door was rotating it. So we freed everything up, took down the short gastrix, and we just added a different type of door so that it wasn't pulling everything over. And that person did very well. This is a picture of POEM, the so-called submucosal tunnel, and then closing the defect with clips. So in my mind, this is great for someone without a hiatus hernia. In someone with a tortuous esophagus, you could try this and then see what happens. If someone has had a prior POEM, people are doing POEM in a redo setting. And this is the New England Journal study from 2019. This is a study that our team, our fellows need to know for the exam. We got to quote it. This is a study about 100 patients randomly to POEM versus 100 patients to Helleran myotomy in a door. And it was found to be non-inferior. And this is obvious. Reflux is more common among the patients with the POEM. And that makes sense to me. If you're to compare POEM to Heller alone, I think they probably would have the exact same amount of reflux. And some people, it's okay. It can be managed without medications or with medications. But this idea, oh, we'll just go back to doing something else. You got to bear in mind that it's hard to go back for a redo operation. And even in this single center, they did have risks of pneumothorax, bleeding, perforation, effusions on their study. So question mark. Do you get good results for type 3? I think if you have a good sense that there's tightness there and the spasm component is not the predominant issue, then you can do it and then see what happens. A dilated esophagus, tortuous, it can be very hard to get into that plane when it's not straight. And yes, it can be used as a salvage operation. So this is my point. This is a meta-analysis of myotomy versus graded dilatation. And if you were to just read the abstract, you would get the sense of something. 1 year follow-up seems not bad. But if you're talking about perforation risk, potentially 9 scopes, dilations over 2 years, that's really increasing your risk of something bad happening. And as I pointed out, making potentially the definitive therapy more hard to do. We chatted about Botox. I like it to get someone out of Dodge if they're admitted, can't swallow their saliva. This is a good thing, knowing fully well that the effects are going to not last, but this allows me to plan out an operation not urgently or emergently. These things are not very good. And I call this crossover therapy. Yes, there are people that we've done surgery after dilation, after Botox, surgery, then POEM, this kind of stuff. So again, I think that it's good to decide between you and the gastroenterologist how you want to play things out, knowing fully well that there are complications and so forth. And that's how I do it. You never want to get into a fight with your referring physicians. Let's just put it that way. They'll just refer to someone else. Obstructed patient, someone comes in, hydrate them, put an NG tube down, put a feeding tube down, this kind of stuff. So the last topic I want to cover is end-stage achalasia. And this is where, over time, not only is the esophagus dilated, it's tortuous, and then it actually hangs below into the right chest. So there's a real gravity problem, a sump problem. And sometimes lower to the hiatus. So here's an example of this. So this could actually be worse. So this area here, this so-called sump area, first of all, the esophagus is not peristaltic. There's angulation now. There's tightness at the GE junction and a gravity effect where stuff is just sitting there. So we have a patient like this that we're planning on operating this summer as an esophagectomy. So this is a real problem. So one would say, well, should we even be thinking about a POEM? Well, it'd be technically hard to do with very not expecting a good result. Should we do a myotomy and see what happens? Can we straighten that out? Can we do a myotomy and maybe pull some of that down? I don't know. And is that going to cause problems with respect to the definitive operation? And then someone might say, well, you are removing an aperistaltic organ with another organ that has poor peristalsis, meaning your stomach conduit. But if you can create a stomach conduit, as per esophagectomy, that is thin, say 4 centimeters in diameter, straight, with no redundancy, and a uncomplicated operation that went well, these patients benefit. So a Heller myotomy can deal with the LES, but not the tortuosity. Some people will say, well, try a Heller first, see what happens. Sure, but I think we know that the patient is probably headed towards an esophagectomy anyways. So it's not unreasonable to think about a Heller. Resect as much of the diseased esophagus as possible. And oftentimes there's a straight part at the top. You may need a right thoracic anastomosis or a neck anastomosis. The bottom line is you want everything to be nice and straight like a tie. And stomach would be the replacement conduit of choice. So here, I think this will work. So this is a CT, and look at this esophagus. This thing right here. And it's actually hanging below and comes back up. So he had a Heller, no benefit years ago. We ended up doing a Ivor Lewis esophagectomy on him, meaning an abdomen first, then a right chest. And he did really well. And as an example, here's the chest x-ray. So the left is before the operation. You can see an air fluid level at the top, this dilated esophagus with stuff in it. And now the x-ray on the right looks normal. So this guy had a good result. Okay, I think we've got our questions. There's two more. So question number 4.
Yes, doctor. Hi. We can share the question panel for the audience so they can answer it. If you may, you can question for them.
All right, so question number 1. What is false about a toupee fundoplication? So what's false? Again, classic exam question. If you don't read it quickly, you don't catch the false part. It is an incomplete wrap. It is a posterior wrap. It is an anterior wrap. It could be 270 or 240 degrees. So which is the wrong statement here?
We'll give them 30 seconds and we'll share the answer. Sharing the answers in 10 seconds. The answer is?
Ooh, so what is false? Correct. The false one is it's not an anterior wrap. The way I remember these things is that the front door and you have a bald spot and you need a toupee at the back, posterior toupee. And, you'll see different textbooks say it's a 240, a 2/3 wrap, or a 3/4 wrap. I'm not measuring these things with a protractor. Another question might be, hey, which of these things is a complete wrap? The Nissen is the only complete wrap, whereas toupee, door, and Belzi are incomplete wraps. So great work on that one. I think we've got one more question.
I think.
All right. This is the classic Royal College question. What is the best treatment for achalasia? Pneumatic dilatation, Botox, poem, surgery of any kind?
Give them 30 seconds, inshallah. 10 seconds. Can you share the answer?
All right. So again, this is a classic question you get at the Royal College that you all leave the exam and everybody says a different thing. I suppose each of these four things could be done at any point in time, right? And often people have had all four, believe it or not. So I would say that POEM is great because it's not a operation per se, it's per oral. But again, in someone who has a hiatus hernia, I think I wouldn't do that in that patient. Surgery is good because you can add on an anti-reflux procedure. Botox, if it's getting someone out of Dodge or if they're in have other serious medical problems and so forth. So I think that I put this in for fun. There's no real answer because it's so vague. So thanks for playing along with that one.
Thank you, Dr. Lee. You have any question for the audience?
Yeah, if I didn't see anything in the chat, Q&A.
There is one question in Q&A, if you want to answer it.
Please explain hiatus hernia, endoscopic surgery. You know, I have to say that people have been trialing all these things. I don't think it's there just yet. I think that in theory, one can do all these things via per oral or so forth. It's just not there yet in North America. So really, we are thinking about if you are going to do an anti-reflux procedure, it's a laparoscopic procedure rather than some kind of natural orifice or POEM or something. So I really don't want to get into something that I don't do, and I'm not 100% sure it's going to catch on.
Thank you, Dr. Lee, again for sharing your time and efforts, for sharing your knowledge with us. Now, we'll finish our session and we'll share the screen for the upcoming lectures. Please feel free to sign and register for them. We'll course up for 5 minutes. Thank you everybody for attending.
And I'll send both these presentations to Sergey Kuwait. And thanks a lot and have a lovely evening.
Thank you, Dr. Lee.